Our theme for our quarter 2 meeting is just thinking beyond the hearing test. So we really want to position tinnitus as an opportunity that may be overlooked in our everyday patient population. So today we have Dr. Danesh joining us from Labyrinth Audiology. His team really focuses on tinnitus. That's what their specialty is. So he's here today just to provide a
Yeah,
very
don't turn it off yet.
to help us identify, assess, counsel, and manage our tinnitus patients more confidently in the ENT setting. So with
Hi.
that being said, I want to remind everyone to please mute your mics. And then I'm going to turn it over to Dr. Um, Danish to kick us off. And I
All
believe you
right.
can go ahead and screen. Yeah.
Yes, I'm going to share my screen. Hello, everyone. Happy Thursday or Friday Junior. I'm going to share my screen. All right. Can everyone see this okay?
Yes.
Okay. So my name is Dr. Danesh. I am a tinnitus specialist in South Florida. And tinnitus is a gray area, as we all know. It's some things that a lot of people don't like to touch. I'm here to simplify tinnitus for you guys, because as a clinician, we want to build our moat around the skills we could provide to our patients. And tinnitus is something that a lot of people deal with. 2.1 billion people in the world have tinnitus, roughly one in five people. And as we know, tinnitus is a big spectrum. So there's a lot of people that may need to seek care for this. So I just want to briefly describe what our clinic does and what our studies revolve around. So we follow the sensation-emotion-cognition model. In essence, to simplify this, sensation is just to reduce the actual sound that they hear in their ears. 7 out of 10 people receive some sort of relief with hearing aids. So whether it's a hearing aid, whether it's a device like Linear to reduce the sensitivity or the sensation of their tinnitus is big. We deal with the emotional components. So this is kind of the one-on-one. Now I know in an ENT setting, you guys are limited on time, but as we know, there's a lot of emotional distress that's associated with tinnitus. And the whole idea is to reassure the patient that the tinnitus is just a sound and that it's very manageable. We want to provide hope to our patients so that they don't go down this big rabbit hole of going on the internet and seeing what everyone has to say about tinnitus. What we say in our field is that misery loves company, and there's almost no one who gets better with their tinnitus and goes on these online forums to talk about it. So just giving our patient hope. And the final thing is cognition. This includes cognitive behavioral therapy. I typically associate emotion and cognition together, but it's all about just reducing the distress that they have with their tinnitus with cognitive behavioral therapy so that they don't feel as hopeless. So this, and can you guys just see everything? Okay. So we have provided evidence behind our methods to show how this works. So, in essence, if we were to go through the three studies we've had through unguided ICBT, guided ICBT, and face-to-face CBT, um, everyone got better. The next slides will show you, but that's just the essence that we know it works, and we really get good data and outcomes from our approach. So the next slide is just going to show everything a little bit better. So in our first cohort, we measured just a TRQ, and we saw a 44.8% improvement from baseline. In our second cohort, where we had guided internet-based cognitive behavioral therapy, their 4C management, which is their confidence of getting better, almost doubled, and their anxiety and depression scores significantly declined by about 50%. And same thing with our face-to-face cognitive behavioral therapy. Their confidence to improve went up significantly, almost twice the amount, and the emotional distress significantly declined. So, how I want you to think about tinnitus is very close to diabetes. So, in the ENT setting, a lot of ENTs will state that there's nothing you can do for your tinnitus. But if we have that same theology with diabetes, which we don't, um, I just want to kind of identify how similar tinnitus and diabetes are. So for both, there's no permanent cure. However, We typically manage it. Now, diabetes is caused by complex physiological factors such as insulin resistance. Also, for tinnitus, it's due to any sort of damage or lesions or obstruction into our auditory pathway. So symptoms vary a lot, as you know, for tinnitus as well and diabetes. So, one patient can have tinnitus and it's non-bothersome, while the other one, there's a big, distress and impact on their quality of life. But they're all managed, right? So with diabetes, we manage it with diet, exercise, and medication. With tinnitus, we manage it with the sensation, emotion, and cognition. And we help our patients understand how to live with it and habituate. And ideally, we improve their quality of life. So it's neck and neck. But for some reason, diabetes has such a the way that physicians may look at it is so different with tinnitus when they're both just conditions that we would like to manage. So again, we may not be able to eliminate your tinnitus, but we can absolutely take control of it. So just having the understand that it's very manageable, that's the most important thing. So let's discuss how we can manage it. Okay, so when I'm doing my tinnitus eval, I focus on a couple of key components. So the first thing is laterality, whether it's unilateral or bilateral, mostly because a unilateral tinnitus is a red flag. So we want to know how long we've been dealing with the tinnitus for. Sometimes acute cases can resolve spontaneously. So we would like to wait at least 60 days before initiating any sort of treatment. We have seen tinnitus go away. So we do want to wait before our patients make a financial commitment, mostly because if their tinnitus gets better, and they've, committed so much, it could get messy. And at the end of the day, we just want to do what's best for our patients. We want to understand triggers. Sometimes it could be cervicogenic tinnitus, a medication-induced tinnitus. So this is actually where the ENT involvement comes in very well, where they can screen for medical issues. Now, characteristics and pitch, we want to understand how the tinnitus is presenting itself. We want to understand how much of an impact it has on our patients. And then, of course, hearing, because we know that in 72% of cases, hearing loss is the cause of tinnitus. In 22% of cases, roughly, it's a lot of noise exposure, but we understand how well we can amplify and help someone's hearing to reduce their tinnitus severity. You guys know how to administer a THI and TRQ. We highly recommend it. That helps guide you to understand what type of treatment a patient should get. If a patient has a moderate impairment or higher, we consider cognitive behavioral therapy. We believe they could get a good benefit from that. If they just have a mild or slight impairment, but they notice their tinnitus and it's annoying, typically we'll just focus on the sensational component. So that revolves, hearing aids, sound therapy, maybe linear, and and typically we don't have to push cognitive behavioral therapy as much. But it's one of those things that every tinnitus case is different, and we just have to take it on a case by case basis. So I'm going to talk about my tinnitus assessment. Now, I know in the ENT, you know, setting, you may not have as much time, but I want to let you know what I do. So first thing I do is I screen the middle and outer ear. So just standard otoscopy and tympanometry. I do a comprehensive audiological eval. If we want to do some sort of sensational therapy through amplification, obviously we need to establish a baseline hearing status for them. Now, the specific things I do for tinnitus are pitch matching, intensity matching, minimum masking level, and residual inhibition. So we want to understand the pitch and intensity because we want to understand where we would like to stimulate our sound therapies if their tinnitus is present. So typically the pitch, most often, of course it varies, but we see it being higher pitch sounds in most patients. Of course, every patient is different, but the intensity is roughly 10 decibels on average, 10 decibels SL from their threshold. So sometimes if it's very, very high, they may not be as good of a candidate for amplification, and we would actually administer something like linear with the idea that we could soothe the tinnitus that way. Now, the next thing we do is minimum masking level. I want to know the lowest level of narrowband noise that can cover their tinnitus. This helps me understand their candidacy for sound therapy and give me an understanding of, how much stimulation they really need and able to get the results that we're looking for. The most important thing of my tinnitus evaluation is testing for residual inhibition. What I do is I present my residual inhibition 10 decibels above their minimum masking level, and I have the patient sit in that masking sensation for roughly 60 seconds. Once I'm done administering my stimulation, which is again 10 decibels higher than the minimum masking level, I will remove the inserts and I'll ask them if they can still hear their tinnitus. Now, if a patient has a high percentage or if not complete cessation of their tinnitus, then they're a good candidate for amplification and sound therapy. You will run across patients that have very low change in their tinnitus with stimulation of their tinnitus. So essentially, if they have very low change in their tinnitus with the stimulation, they would be better candidates for something like linear because if they don't have good receptiveness to, amplification and targeted sounds, hearing aids may not actually be the best for them. So we do know, like I said earlier, 7 in 10 patients report relief with amplification and sound therapy. And again, residual inhibition is very important for that. So one thing that I've noticed a lot with tinnitus is I've been hearing a lot of different things and misinformation on the internet. I do have my patients stay away from the internet as much as possible because, like I said earlier, misery does love company. So a lot of people are going online and spewing a lot of information that is actually incorrect. One thing that I've been seeing a lot is that, tinnitus leads to dementia. This is something I personally don't agree with. We know that, hearing loss is a big component of tinnitus, and hearing loss can lead to cognitive issues and memory issues. However, I'm not going to strike fear in my patient because it's not good for their overall outcomes. I'm usually very hopeful. I let them know that tinnitus is just a sound. It's not going to hurt you. It's not going to kill you. It's just some sound that they currently find annoying, and it's a sound that's very manageable. I explain that the brain has neuroplasticity and it's very good for habituation. Tinnitus is relatively a non-threatening signal, and the way we interpret sound is very different. If I go in my kitchen and I hear the humming of my refrigerator, that's not something my brain will react to. But if a pregnant mother had just given birth and she hears her baby crying from across the hall, it's going to strike a fight or flight response essentially and have her jump up immediately. So the way our brains react to certain sounds can really vary. And the idea is that we want to teach the patient that their brain can treat their tinnitus like the humming of a refrigerator, for example. So I do want to shift from the theology that nothing can be done from tinnitus. We have the data, the studies that show that there's actually a lot of improvement that can be done. On average, we're getting at least a 50% improvement from baseline. So just like diabetes, it can be managed. And the best way we manage it is following our SEC model. So sensation, emotion, cognition. That means dealing with, the actual sensation with hearing aids or linear sessions in person and also cognitive behavioral therapy. Now, what I personally like, and everyone is different, but I'm going to tell you the hearing aids that I like the best for tinnitus management. Resound is very good. They do have a lot of flexibility for the patient in terms of sound therapies. Now, I know some people may feel like Resound can, everyone has preference in terms of sound quality, whether that's the clinician or the patient. So, of all the hearing aids we work with, these three, Resound, Starkey, and Oticon, are my personal favorites. Um, so, Resound, like I said, that tinnitus sound generator app, you have a lot of flexibility. The Starkey multiflex tinnitus technology is very good because you could base their tinnitus sound therapy off of their audio, and then you could tilt the frequencies that it essentially stimulates. So we do want to match the pitch of their tinnitus there. Oticon is really good because it provides good sound quality. So it also provides a lot of different types of tinnitus therapy. It can match the audio like Starkey does, but it does have limitations in terms of, like tilting the frequencies. But you can go in actually that programming and adjust the specific frequencies you'd like. Now, the idea of tinnitus treatment is we're not actually try to completely take away the tinnitus and completely mask it. We do want to have it in line where a patient can just barely hear their tinnitus, very minimally, but so it does revolve some subjective programming. I am adjusting based off what the patient is telling me. And again, we do provide flexibility to the patient to adjust the tinnitus, sound and the therapy intensity. So we do let them know that it's not like we want to completely take the tinnitus away, but we do also understand that tinnitus may fluctuate and we may need to compensate for that. So I did put linear in here. I know you guys aren't providers with linear. Again, I mostly give linear to patients who have tried amplification and sound therapy with limited to no benefit, or patients who have no residual inhibition. I do think personally that sound therapy is still the better approach of the two, but there are good candidates for both. Like I had a 22-year-old patient the other day with no hearing loss and tinnitus, no residual inhibition. We did 12 weeks of linear, and after treatment, he said that, his tinnitus used to feel like it was by his hip, and now it's way down the hall. So it's all about soothing the tinnitus. I think that if a tinnitus patient, you feel like they may not be as beneficial from hearing aids, it's okay to refer out. I mean, there's nothing wrong with that. At the end of the day, we need to do what's best for our patients. But yeah, these three hearing aid manufacturers, in my opinion, have the best tinnitus programs. Now, I want to talk about a form of cognitive behavioral therapy. Tinnitus patients require a lot of time. Personally, my clinic uses something called Odo. Odo is a cognitive behavioral therapy app. In my opinion, it currently is the best one, and it's what we administer to our patients, mostly because you can administer it to the patient and they follow the 12-week protocol themselves. So it allows you as a clinician to give excellent care for the patient to get accessibility to care without having it take too much of your time. And the outcomes are very good. It's very comparable to the outcomes we have with face-to-face CBT. So, I usually give this to patients who have a smartphone and have a moderate or higher severity or handicap with their tinnitus via THI or TRQ. So, this is just some ideas of how Odo and apps and one-on-one therapists CBT are very similar. So I don't know if you guys give out CBT, but when it comes to the care we provide to our patients, it's very important that we administer as much as we can to help the patient. We do understand that the sensational component of tinnitus is something that is probably the first on our list, but the impact that cognitive behavioral therapy has on our patients is very high. So we do want to take a multi-pronged approach to enhance our patient outcomes. So the key takeaways, so tinnitus doesn't have a cure, but it's very manageable, very closely to diabetes. We do use the SEC model. We address sensation, emotion, and cognition together. Our best outcomes are when we do the cognitive behavioral therapy sessions in person and provide hearing aids or some sort of amplification slash linear. We have to ask the right questions. Sometimes tinnitus can be reversible, and that's when your referrals to ENTs, which you work with, are very important. If a medical issue is present, we would like to deal with that
I'll
before
be fine with guy.
we address
I'll be fine
anything.
with.
So THI, TRQ is very important to help guide your treatment and referral decisions. Um, when I'm specific with tinnitus, we do pitch matching, loudness of tinnitus, minimal masking level, and residual inhibition. Residual inhibition is very key to understanding how well of a candidate they are for amplification. Resound, Starkey, Oticon are great tinnitus programs, and Linear is a good alternative. Um, Counsel your patients, tinnitus won't hurt them, and we have a plan to help them. If you guys have any questions about specific tinnitus cases, you guys can always contact our clinic. Sometimes for very severe CBT tinnitus patients, we can provide one-on-one CBT. So that's something that I could also coordinate with Lindsay. But I'm sure you guys may have some questions. But I want to thank you guys for your time. I tried to be quick at 4:25, so not too bad. I know you guys want to get home, so appreciate you guys for having me here.
Absolutely. That was great. Thank you so much. I see one question in the chat. Jamie is asking if there's a cost to the app. Jamie, yes, there is, and that's something we can talk about after this. We are going to lead into a little bit of a conversation about access to that app. Natalie just asked, can you test residual inhibition with tinnitus masking programs in office during a hearing aid consultation?
So how we test residual inhibition, you do have to pitch match first. So you have to understand where the tinnitus is. The next thing you want to do is understand the loudness. So once you understand how loud the tinnitus is and where it resides for the frequency that it is, we're going to use our minimal masking level. So the minimal masking level is relatively similar to the intensity in most cases. And the reason why we need those three things, it's because when we understand where the tinnitus is, how loud it is, and how little you need to mask it completely, we have to add 10 decibels to that minimum masking level to appropriately provide residual inhibition. So typically, I have my patients in the booth. It is difficult to have it out of the booth, but again, 60 seconds of that narrowband noise most often at that frequency and 10 decibels above that minimum masking level is how we can accurately predict how well they can do with residual inhibition. Did I answer that okay?
Yeah,
Hope
I think
so.
that was pretty clear.
All right.
Does anyone, she says thank you. Does anyone else have any questions? You can either unmute yourself and ask or throw it in the chat while we have the expert here. No? Okay. I think we're good. Thank you so much for that presentation. That was really impactful for our team, and I think that you gave us some great takeaways that we can take back to the clinic. So we appreciate your time.
Yeah, and if you guys have any questions, I'm gonna drop my email in the chat,
Thank you.
and I'm like an open book, so this is my clinic email, and you guys can just contact us with questions. Okay,
Thank you so much.
it's my pleasure. Thank you guys. Have a great weekend.
Thanks, you too.
You too.
All right, bye.